Good afternoon. I'm Dr. Ron Kennedy Bailey, currently serving the role of Deputy Surgeon General for Mental Health for our Alpha Phi Alpha Surgeon General Initiative. Welcome and to join our program this evening. We're talking about emergency medicine this evening. For all of you who've heard many of our programs in the past, we actually try to change our topics up quite a bit, but to make sure we address issues of great importance. I'm very pleased to have really three outstanding emergency room physicians in psychiatry and primary care with us this evening. All doctors who've touched these issues of emergency concerns in our community. Jeff Sterling in Chicago area and Fort Worth, Texas now. Mike Oko in New Orleans, and Steve Bryant in Miami. Let me begin by introducing each, and then we're going to go to Dr. Sterling initially. On a panel today, we actually have Dr. Steve McLeod Bryant. Dr. Bryant is born and raised in Binghamton, New York. He's in the University of Rochester, where he's a member of Mu Sigma chapter of Alpha Phi Alpha. He received a BA, magna cum laude in cybernetics. He received his MD at the University of Rochester in 1984. He completed his residency in general psychiatry at the Tufts New England Medical Center in Boston. After finishing his residency in 1988, he became a faculty member at the Department of Psychiatry and Behavioral Sciences at the Medical University of South Carolina. After 24 years at MUSC, he left Charleston to join me. I'm very pleased to have him do so with his excellent activity at Meharry Medical College in the Department of Psychiatry there in 2015. He left Meharry to join the University of Miami Department of Psychiatry and is currently the clinical associate professor in that setting. Dr. Bryant is a recipient of the American Psychiatric Association's Solomon Carter Fuller Award. It's the top award for psychiatrists in the APA. He's a member of the American College of Psychiatrists and is currently the president-elect of the Black Psychiatrists of America. He's married to Dr. Sarah Denard, a child and adolescent psychiatrist, has 3 adult children, Sydney, Andrew, and Aaron, and granddaughters, Audrey and Amelia. And we're going to welcome Dr. Bryant. Next up is Dr. Michael Okonkwo. Dr. Okonkwo is a 4th-year resident in emergency medicine here at LSU School of Medicine, New Orleans, where I am. Very happy to have met him and work with him in our department and in the ER department. His career focus is DEI, or diversity, equity, and inclusion research. He's going to speak a bit tonight about a program he's involved in New Orleans, actually working to train and involved in a violence prevention program for young African males here in our community. Our third person this evening, he's very little introductions with us pretty regularly. Our Surgeon General for the Alpha Phi Alpha SGI initiative is Jeff Sterling. Dr. Sterling and I have a long co-career. I think we both finished med school, he in Chicago and me in the Houston, Texas area 3 decades ago. I've admired his work for an extensive period of time, including the other work he's doing now in Fort Worth, Texas, going forward. So we're going to start tonight with Dr. Sterling, and I'll present a couple questions to you, Dr. Sterling, to kind of give you an opportunity to kind of start off with some key issues. As an emergency medicine physician, what have been some of the most significant challenges you've had dealing with emergency psychiatry patient presentations in general? On top of that, I'm going to ask you what particular key elements that are relevant for African American males in emergency room presentations that we as physicians should be mindful of, and as families and communities should be thoughtful about. And third, I want to also ask you kind of going forward, are there any prevention strategies that you think our audience should be very mindful of and aware of to decrease the likelihood that persons have to present to the emergency room, where very often the short-term focus of emergency care is misinterpreted as a place to go for long-term care for chronic kinds of concerns? Those are my 3 open questions for you, Dr. Sterling.
Well, let's start with the first. So for the sake of the audience, let's go back over the first. Before you do that, let me tell you guys a story. And first of all, on behalf of General President Willis Lonzo III, welcome everyone, and thanks for this fantastic panel. I always love seeing our expertise, and obviously yourself, my good friend, Dr. Bailey. Just by way of introduction, to give people the scope of some of this, many people don't really realize that an emergency department and an emergency room are actually different things. There are many different components of emergency departments, and I've personally run 3 different level 1 trauma centers in different parts of the country. And in addition to that, my company had the pleasure of rebuilding the emergency department at Connecticut Children's Medical Center. And as part of the emergency department, and this is probably 15 years now, we actually built an emergency psychiatric division of the emergency department. So that was for kids. So just to show you what the scope of what it is that presents to the emergency department, if the volume in a children's hospital is such that this is being considered much less implemented, it really speaks to the volume and severity of the types of things that show up into the emergency department. So that's how long we've been having these conversations. Now to your questions. Hit me with the first part of your three-parter again.
It was a three-parter, and I'll make it brief. So one issue simply is, as a African-American ER doctor, what are some of the most substantial challenges you have when patients come into the emergency room? I think those are issues that are very general for all of our audience.
So there are two immediate things to come to mind, and I can tell you just by way of introduction that there have been no fewer than maybe 10 different patients that I've seen in the last week that presented for these exact same considerations. And there are always two considerations. One is that we have to make sure that what we call organic presentations aren't being confused with psychiatric considerations. There are a lot of medical conditions that actually can present and manifest themselves via psychiatric misperformance. And we have to first rule out those considerations in an emergency department setting before we can actually ascribe what is actually happening to behavioral health considerations. So that's a very important concern. And so we just don't get people into the emergency department and immediately label or start treating them as if this is a psychiatric illness. And that's something that the general public would do well to understand, is that your family may not be crazy as you would be inclined to say. There really could be a serious medical issue going on, and please consider that. The second consideration is along those same lines. People do misunderstand people that present with psychiatric challenges, particularly in an emergency setting in which things are starting to go off the rails. I can tell you, and I wish we had time to go into this into great detail, the stories we each could tell on this, having to literally fight the police or to put them in place, literally, because of their inclinations to handle these individuals in a certain way, having to let it be known to family members that this is a medical emergency in addition to being a psychiatric emergency, and even controlling your staff's worst inclinations about the patients that are presenting. So part of what we have to do in an emergency setting and in an emergency department setting is to stay above the fray and to keenly assess what exactly is presenting, instead of necessarily ascribing it to, oh, there goes somebody that's off their rocker. It's a very important consideration in order to treat them with the respect and the appropriateness of care that the situation calls for.
Tiny points. I clearly think that understanding these issues are relevant. And I think understanding them in regards to, African-American patients, especially young African-American males, can also be, I think, a very key issue for our audience. Not only tonight, but on prior nights when we've actually had this SGI program in the chat, quite a bit of what comes in from our audience often revolves around what some of their own individual experiences have included and how one might be able to manage or kind of help or assess them. Let me move to Dr. Bryant and kind of give him the floor, give him kind of respond to some of those issues, and also share some of his initial considerations of our overall theme tonight, talk about emergency medicine and what African-American patients and families should be mindful of.
Well, following up on Dr. Sterling's points, I mean, one can think of the reasons for coming in for a psychiatric emergency broadly in three sort of different areas. One is that a person is being a danger to themselves, suicidal, or acting in a way that is harmful to themselves, or they're appearing to be dangerous to other people. They're agitated, they're striking out, they're attacking other people, they're threatening other people, or they appear not to be able to care for themselves because of their behavior. They're frightening because of just people don't know what they're going to do. They're very disorganized or unpredictable, impulsive, and that causes them to be brought into the emergency room. A key point that I want to underline that Dr. Sterling brings up, and that's very troubling when it comes particularly to Black people being brought into the emergency room in a psychiatric emergency, is how often the police are involved in this particular circumstance. Oftentimes, people, because of the perceptions, the stereotypes in the community, particularly a Black male acting somewhat impulsively or acting in a way that frightens other people, even though they may not be meaning to be frightening, oftentimes gets the police called and the police become involved. And this is a situation that we can talk perhaps more specifically about how to prevent police involvement. Once police do get involved, what sort of steps that we can take to try to minimize the chances that violence against the Black patient occurs, and ways that we can get the treatment, the necessary treatment, oftentimes medical treatment for these individuals, instead of incarceration or a trauma that oftentimes occurs in these situations.
But Charlie points, I clearly think that the understanding of what the relevant risks are matters greatly. And obviously ER doctors are trained to make those assessments very quickly. I make the point of one of my 3 early questions is also to give you guys a chance to kind of address to the audience, what are some of the challenges in ER medicine when families or friends or patients tend to think that they can get their long-term or chronic issues met or addressed in that setting as well. We always talk about patients going to the ER when they really should have gone to the primary care doc. And that seems to be an overriding issue here where I'm in New Orleans. I may punt to Dr. Okoronkwo and give a chance to kind of jump in.
Yeah. So a perspective that I consider when considering emergency psychiatry and emergency department is actually from Black young males and actually Black young adult males who are victims of a violent crime. I think about victim vulnerability and their increased risk for recidivism as it relates to violent crime, and really mitigating that risk is a care focus that I apply. And one strategy that I actually consider is trauma-informed care. And I find that to be very riveting and actually empowering. And it helps the patient to mitigate those risks, which are actually there, and they have voiced such risks to me. And for me, that's an important component of care that I strongly consider when I consider the overall scope of emergency psychiatry.
Dr. Sterling, thoughts about that? Clearly, it's a discussion we have quite a bit. I think I mentioned on this podium before that we're very fortunate here at LSU. Last year, we actually worked on it. Just this year, we got a $1.3 million annual grant for 5 years to address this thing that Dr. Okoronkwo points out very articulately, this issue of trauma-informed care, to recognize that so many individuals who kind of come into the ER have previously been traumatized, or their families have, and that actually very often affects them, their ability to respond, their tendency to be compliant or not so with treatment you recommend, and overall outcomes. Interested in your thoughts about what we should be considering, because some patients come in very different than others when they come into the emergency room.
One we lament in emergency medicine, let me just take you back historically, not too far though. There was a point in time before implementation of the Affordable Care Act where 50 million Americans were without health insurance. And the goal of the Affordable Care Act was to provide about 30 million of those individuals with some form of health insurance. Prior to that, and even now with those individuals that are still without, the emergency department all too often is their portal of entry into the healthcare system. So in emergency departments, we care so much about what's trying to kill you, even more so than what your ultimate diagnosis ends up being. However, psychiatry represents an important distinction, because out of all the people that come to the ED, emergency department, looking for primary care, this is one time where we actually take a step back. So instead of just rapidly assessing patients and returning them back into the same conditions that produced their pathology, with psych patients, we actually tend to slow down. It's very important in this patient population that we take our time and try to arrange and coordinate outpatient care in the event that they don't have a life-threatening emergency that needs to require institutionalization. So one of the things that I applaud about what it is we've evolved toward, and again, I will speak again toward divisions of emergency departments that focus on psychiatric considerations, is that we do take our time. Sometimes patients end up being held in emergency departments for 24 or 36 hours because we really are careful not to send them back into a situation, particularly, as Dr. Bryant was saying, if they have active suicidal ideation, if they have a plan, if they came after a suicide attempt. You don't want to just discharge them because those patients often will come back on a stretcher going to a morgue. So yeah, we really have to do a more thorough job on those patients than we may otherwise.
Interested in really each of the opportunity to kind of address what some of your most challenging cases have been. Many physicians can sort of think about that, and I think that many of us have our own individual experience. As an individual, I at age 7 fell and ride my bicycle in a canal area and bust my chin and went to the ER, and I can remember everything about it. And that was 50 years ago, because very often what may have been medical certainly was emotionally traumatic to the individual, whether a young person or otherwise. I imagine that may present some additional challenges in the ER setting or any kind of an acute care or crisis manager type event. Dr. Bryan, any thoughts?
I think one of the most challenging situations that I've encountered is something again that Dr. Sterling was alluding to, in that in many situations, particularly in our urban areas, where there may be more demand for services than there are available beds, for instance, for inpatient care, how to manage people with psychiatric emergencies in the emergency department, whether there is a dedicated psychiatric emergency space or if there isn't one, managing someone with a psychiatric disturbance in an emergency room bay where it's not built for providing the sort of comfort and care that that particular patient needs. And it's frustrating for the patients, frustrating for the families, and it's frustrating for psychiatrists. And it speaks to the need for greater resources devoted to mental health care. The Obamacare revolution, if you will, not only was meant to give additional resources to the uninsured, but it was also to bring some parity to how we provide resources for psychiatric care as well as physical care. And in many ways, this country has been negligent in making sure that those resources are available to treat psychiatric emergencies.
One also wonders, do you find differential capacity to provide satisfactory or optimal care based on resource allocation in emergency rooms? It often strikes me that we talk so much in healthcare about how it varies remarkably. In some places, there's just more resources, more money to provide care. But some populations, I think I've alluded to earlier, may get more overall care, whether it's ER care or short-term or long-term in ER type settings.
Yeah, absolutely. Certainly we know that much like with public schooling and other resources in America, that where the need is often greatest is where the resources are the least. And this is something that needs to be addressed politically, but obviously in the here and now, as emergency room physicians and psychiatrists, we have to do the best we can with what we've got.
Let me pick up something that Brother Dr. Bryan just put down. People would do well to think about the evolution of how we've treated patients with psychiatric disorders in emergency department settings just in my professional lifetime. Patients once upon a time were actually given electric shock therapy, right? We would burn the crazy out of you, so to speak. It's a horrible, horrible thing. There was a point in time in which patients routinely were being put in straitjackets where they were being restrained, etc. There was a point in time in which everyone was institutionalized. Then there was a point in which people were criminalized. And in today's society, the exact same people with the exact same mental challenges are left to their own devices, and in many instances represent homeless, members of the homeless population. So the pathology hasn't necessarily changed. Society's response to it has. And what Dr. Bryan was pointing out is that so many of those people now show up in an emergency department setting. And the point that I made earlier about discharging them back into the same conditions that produce their pathology is something that society simply has looked the other way on, because they don't have access to resources when they show up to the emergency department because they don't have anywhere else to go. They don't have resources when they go back to their homeless existence. And the point you made, Dr. Bailey, is so on point. Resources matter. So in these psychiatric ERs that I've been able to set, imagine, if you will, the utility of my being able to call an on-call psychiatrist inside the facility, inside of an 8 to 12 hour window that's required. If the hospital is able to contract with that individual to come assess the patient in an emergency department setting and definitively deal with that. That's a very rare thing. It certainly isn't happening in rural settings, and it certainly isn't not happening in small urban settings. Compare and contrast that to the situation in which people are homeless, coming off the street, and they're looked at a certain way, disparaged, and not dealt with definitively. So much of this conversation has societal overtones. It's just very important to point that out as we get to the part of the conversation where we talk about what we can do, how we can empower people, and how we can effectively address these challenges.
Tiny points, and I'm going to give Dr. Oko a chance to kind of respond, and I'm going to share an experience I had when I was a first-year intern, and a patient family walked up to kind of complain that they'd been in the hospital for 24 hours. And I will give each of you guys a chance to discuss what the process is like where you are. Clearly, you make the point very clearly. Sometimes you have to kind of call a doctor, especially from outside the facility, to come in. When I was in North Carolina, it was a 24-hour window. To get there in 8 hours is actually pretty fast, but for families, being in the ER for a long time can be very uncomfortable. But Dr. Oko, let me give you a chance to kind of respond, and maybe your own experiences, but also kind of what happens at LSU in New Orleans.
Great point you reference, Dr. Sterling. In lieu of that point, I like to consider structural racism. Now, the greatest attack on structural racism, from my perspective, results in attack on resilience. And that flaw, that limitation, is what results in a lot of these presentations for psychiatric emergencies. And what I like to do is actually translate the impacts of structural racism into longitudinal projects and outreach in the local community, which actually functions here in New Orleans as community rounds. We actually partnered with the New Orleans Recreational Department to form Health in Hoops with Doctors. And what we do as a group of medical providers, we provide a curriculum, positive youth development, in which we enrich local New Orleans youth with pro-social development. We develop character, competence, confidence, compassion, the 5 C's that are integral in promoting pro-social development. In this organization, this mission is as a result of the limitations in terms of psychiatric care, in particular for minoritized communities. It's very evident that physicians, providers alike, there's more of us that can be done potentially to kind of help reduce the gaps that are available for our minoritized youth. So I think that's a huge consideration when thinking about different resources that can be afforded to this particular population.
That's a point I think I mentioned in the introduction. It's an outstanding program Dr. Oko runs here in New Orleans. We're very proud of him and his program. You do hear a fair amount about these kind of programs around the country now. Barbershops increasingly now are a term people often use, where different individuals around the country are trying to find ways to address violence prevention. So I wanted to kind of move the conversation toward the issue of violence prevention, strategies to modify these concerns. Clearly, at the forefront, very often, forward-facing the hospitals when issues of violence are growing in that community, are ER doctors like yourselves, or doctors with patients in various forms of crisis. Be interested in all three of you, your thoughts regarding what might we be doing right, or what should we be doing different or better, to Jeff Stewart's point earlier, to manage these kind of concerns on violence and violence prevention in our communities. Dr. Sterling, any thoughts?
Yeah. This is why I respect you guys and what you do so much, because you're practicing medicine and you're dealing with the science of it all, and you're also juggling the societal impact and the decisions that politics brings to bear. So the impact of something like violence in communities has both direct and indirect ramifications in terms of producing psychiatric pathology. So I'm always fascinated at how well you guys do to both address that on the individual patients on the micro level and advocate for better policies and situations that can improve and reduce violence on the macro level. In an emergency department setting, however, I don't, in my experience, don't have that luxury. I simply have to deal with the hand that I'm dealt. Something about keeping your head when all about you are losing theirs and blaming it on you comes to mind.
Before.
We are simply left to manage the consequences of the decisions that families, sometimes other physicians, and society at large make that impact the mental well-being of these patients. So it's too bad that in our specialty, we just have to kind of meet them, greet them, treat them, and street them. But there really has to be a partnership, and we've tried to evolve toward that, as I said before, toward ensuring that the very least that we can do in our specialty is to deliver them to the experts that really can integrate some of these additional considerations.
Other thoughts?
Well, I think one of the things that typically marks the psychiatrist apart from other specialties in medicine is that we're often taught, and it's emphasized, that to see our patients in the biopsychosocial cultural model for understanding the totality of their illness. And I think that's what leads to programs like what Dr. Ogaranko is referring to, and other brothers across the country are trying to initiate in the community to build resilience, understanding that there's systemic issues that are creating or at least facilitating the emergencies that we're seeing in our emergency room, and understanding that we can't do it all just by individually treating each patient, that we have to do something to help our communities become more resilient. And one of the leading predisposing factors that leads to the violence that we see is early childhood trauma. And many of our families that our children are being exposed to significant amounts of trauma at home, whether that's through abuse or neglect, or witnessing violence, domestic violence within the home, or witnessing violence in their neighborhoods, in their communities. And being able to go out into the communities and have programs that will help them to deal with that trauma, to build some support, to avert that trauma is crucial if our communities are to survive in this country.
Interested in your thoughts regarding whether you see differential presentations for different groups: gender, male, female, age, teens and young adults versus mid-aged, let alone other type demographics. The reality is, in some of our settings, where the ER is located does matter. When they plot these diagrams, you can see where so much of the violence happens. In fact, years ago, there was a article in the front page of the newspaper in New Orleans, not last year, but some years back, where they had 365 murders in a year. At some point, they topped out at 465, got down under 200 last year. But the reality is 90% of these 300 plus murders had happened on 10 different corners, intersections. So very often the qualitative value of worsened violence is their geographic. So certain ERs, based on where they're located, tends to matter. I know we talk about violence issues now, but I just comment that I was visiting Jeff Sterling's favorite city, Chicago, some years ago, and they were discussing the fact that when they closed down the emergency room, I think it was at University of Chicago, which is on the south side, south of the Midway Airport. It became more than a 20-minute ride to these big fancy ERs that were all in downtown Chicago or Northwest. And part of the problem was when TPA came out, you need to get to somebody within 20 minutes or less. So where ER is located also matters. We talk about stroke and or violence. So just your thoughts about that. We may start with you, Dr. Okonkwo, then I'll go to Jeff and Stephen.
For sure, yes. So the ER where we're located in is actually in one of the areas where poor social determinants of health exist. And it's as to no surprise that region is actually a part of the demographics here in the city, where we have a lot of prevalence of violence. And so that interesting perspective really highlights the need for community-based approach when it comes to addressing needs in the community. And interestingly enough, the patient population at the institution where I'm at actually presented their needs, and their overall number one need was actually behavioral therapies, which increased resilience for behavioral abnormalities. So I found it interesting. So we have this patient population who actually has an interest and who actually express a need for such services. And that's of note because it's often considered that these particular individuals don't actually have an interest to address such needs. Mm-hmm. So merging these two thoughts together, it just drives the importance of just recognizing communities, recognizing needs within the communities and responding to them appropriately. And that's actually what inspired this work that we do with the local recreation department, where we use basketball as the tool, which actually facilitates positive youth development.
We're going to come back to that. That's a tremendous point, and I don't want to cut you off. I do want Dr. Sterling kind of the last word on it. He has a 6:30 hard stop. We'll come back. I want to get to the barbershop, to the basketball piece next. Dr. Brian, but Jeff Sterling, I want to give you a chance to make any final comments.
Yeah, I want to speak and start a conversation that can be followed up near and far to advocate for some level of innovation. Consider, if you will, the fact that we have designated trauma a sufficient enough medical and public health scenario in which we have trauma centers here, there, and everywhere. We have pediatric hospitals. We have psychiatric institutions. Okay, there's a distinction in that difference. I would actually suggest that in the same way that the incarcerated once upon a time had an equal focus on punishment as well as preventing recidivism, as well as reform, some effort to actually address a level of functionality would be in order for the types of patients that we see. The social determinants of health have been an increasing part of our conversations over the last decade. We understand clearly that the conditions in which you find yourself contribute to your mental and your physical well-being. If we understand that on the front end, adequate and a more complete level of treatment should include remedying those considerations on the back end. And I would hope that a better mousetrap, in addition to the models of care that we provide to patients that have behavioral health, psychiatric illnesses, could, at least in selected parts of these populations, address functionality and whether or not we can help improve the conditions. Because as I've said twice, this will be the third time, otherwise we simply are returning them into the same conditions that not only produce their pathology, but can predictably continue to produce their pathology. I love this panel. I love the work that each of you all are doing. I love what this conversation is doing. As always, I appreciate you, Brother Dr. Bailey, and continue it going. We will seek to advocate for some of the things that we're discussing as part of the Surgeon General initiative moving forward. So thank you. And on my end, I'm going to say goodnight and leave it to the rest of you gentlemen for the rest of the evening. Thanks again.
Good to have you, young man, as always, timely, and you be safe. Appreciate your time. I'm going to go to Dr. Bryant. Lots been kind of teed up. I'm kind of happy we've got at least to 6:30, now 7:30 Eastern, without getting the suicide just yet. Kind of hard to have an ER talk and I get the suicide at all, but there's just so many huge issues, I think, for us to address on this concern. I want to make sure each of you guys have a chance to kind of follow up on a point regarding the social determinants of health that I think Dr. Concord just brought up. But also I think how we actually manage resources was the point I thought that you spoke to well earlier, Dr. Bryant. Let me come back to you and maybe just kind of follow up on that point.
Okay. Well, Dr. Sterling talked about innovation, and one of the things that, or one of the ways that we could be more innovative is taking the precious dollars that we have to provide services and treatment and come up with more cost-efficient ways of delivering services in the community. One of the problems with the current healthcare system is that there's a lot of dollars tied up in the buildings and in the sort of the infrastructure, the institutions that Dr. Sterling alluded to, and not a lot of resources in the people, whether that's training or the actual specific clinicians that could be effective and helpful in terms of turning some of these things around in the community. And again, the sort of the focus is traditionally been on those set buildings, on the emergency rooms and their structures, as opposed to bringing the resources to the people as close to where the people live as possible. And that's the direction that we need to continue to push when we're thinking of solutions.
One also wonders, I'll kind of stay with you for a minute, Steve. I think that one also wonders if this aberration in resource allocation also comes into play, because as social determinants of health come into play, they're often minoritized, let alone, lacking resources. Patients are trying to get that type care. The truth is, we probably have to find ways in the settings that we're in to push for and allocate for adequate and optimal resources where the people are going to be and the persons are going to be in those settings where the needs are greater. I'm interested in your thoughts about Miami. I know you've been in Miami for some time. Do you think that these issues are better there in a very multicultural environment? That's, I think, as I understand, Miami is as multicultural as probably any city in the U.S. next to maybe New York and Los Angeles, as compared to other settings that where we are in this Delta area, Mississippi and Louisiana. You tend to have maybe a couple ethnicities and not the plethora of ethnicities that you may have in a place like Florida.
Well, it's an interesting and it's very challenging environment here in Miami. It's true that we have a great deal of diversity, and that provides a challenge, not only in terms of the Latinx population, which represents 2/3 of the population here in Miami, but in the Black community we have African American, but we have a large Haitian Creole community, which has its own language, its own culture, and not to mention other populations as well. And that diversity provides a challenge and at times a barrier. And one of the resources that we haven't talked about as much, but is important in terms of building resiliency in our communities, is the resource of education. And particularly in our communities, one of the social determinants that will lead to trouble for us, and I think to some extent psychiatric emergencies, is not having the information, not having access to the knowledge as to what might be going on or how to handle certain situations. And here in Miami, that's a very difficult nut to crack in terms of being able to convey culturally appropriate information to those who need it. Having enough translators to translate information, not only in terms of verbally, but in terms of written content, having culturally appropriate messages to communicate about all sorts of issues. This not only affects psychiatric emergencies, but the recent pandemic. We had all sorts of challenges in trying to get the appropriate information to different communities to help them to best deal with the stresses of the pandemic. And so I think education is a major resource that in a diverse community has to be addressed, and we oftentimes don't have the effective resource to address the inadequacies that we have in our communities.
A lot of thoughts come to mind, and I may come back to some of that in a bit, but I want to make sure I don't forget, and with 20 minutes to go, you think quickly. When I tap into Dr. Okoronkwo's multiple past experiences, he was a football player, a college football player, and it's hard to do these discussions now and not have some discussion about what happened on Monday Night Football last year with the guy Hamlin. I was at a dinner party a few months back with a lot of my mid-school classmates. We spent an hour discussing what families and others should be mindful of. These things maybe not quite at that level, but certainly can happen that can lead to emergencies for people, very often young persons, very often kids and what have you, playing sports. Are there other risks, Dr. Concord, that as an ER doctor, you wish families and communities to be mindful of, things that they should do maybe to provide some degree of safety, preventive care, and also thoughts that a household person should respond in semi-emergent, if not emergent situations?
Yes, for sure. So Hamlin's case is a great example of what access and what being educated on how to take advantage of the resources that are available can provide in terms of preserving health. Now, Hamlin was fortunate that there was a defibrillator nearby. And when speaking about how communities can help, ensure safety amongst community members, one thing that comes to mind is stop the bleed in terms of applying tourniquet to reduce the risk of ongoing bleed or hemorrhagic shock or individuals essentially bleeding out to death. There's some simple skills that people in urban communities can actually acquire in terms of reducing the risk of bleed. I think certainly in New Orleans community, but I do believe in nearly all urban communities, there are courses that are offered free of charge in which individuals in the community can learn simple techniques that can essentially save a life. So that's a critical tool and resource that I think is notable to just kind of put out there and to really advocate for and to inform the audience and kind of get them thinking about these types of things.
It comes to mind. I mean, really, I think for many of us, few have not played girls soccer, boys baseball, whatever the case may be. And at some point, there's an event, and there's a kid there. Very often, it could be a young kid if it's little league, and they're 10 or 12 years old, or it could be a high school kid, if you and the like, and problems happen. The reality is, I must admit, I thought about that a lot in this recent football game. I'll go ahead and mention, I was watching Deion Sanders' team, and they were playing this big game on Saturday. I think it lasted till midnight. And there was a play where I think their best player got hit right in the chest. Because I thought about the Hamlin situation and just began to wonder how often does that occur. We all have read so much more about this, I think it's called commodio or commotion, when you get a pop to the chest, so to speak. But all too often, even when I was growing up, it was a young person who died. And folks didn't really know how to respond. So issue about prevention and education along these lines have additional value to the psychiatric measures we talked about earlier in regards to what we do, I think, in ER settings. And the goal of this program is to educate our audience and focusing on emergency room issues, I think, are key. Are there other thoughts that you'd like to kind of share with the audience, not just on that particular very violent issue, but other kind of concerns along that line that young people or parents be mindful of for their young people?
Yeah, for sure. One topic in particular that I really want to address and make sure the audience is aware of is a concept of strength-based interventions. Now, because of racial socialization, culturally, we have tilted resources and access to tools that can enrich and increase resilience towards the non-African American audience. And one thing that's important is when considering the concept of self-efficacy and strength-based interventions is that individuals can recreate a setting of intervention in where you apply tools within that culture, different skills within that culture, such as using basketball as a means to teach kids about safety, using a barbershop to teach. I think there was that great study which showed compliance with antihypertensive regimens with men due to barbershop, intervention. So when thinking about, self-efficacy and strength-based interventions, it's important for that particular model to be considered when thinking about how do we reduce gaps in certain healthcare outcomes to improve the overall health of individuals who are affected by racial socialization in such a way.
And I thank you very much for those comments. I think that's important, I think, for our entire audience. I did tee up the issue, I think, of suicide earlier, and we probably will spend these last 15 minutes on what very often is the sine qua non issue of a discussion of ER medicine. I do want to go to Dr. Bryant first, as a psychiatrist, your thoughts about this issue in general over time. I'd also like to particularly kind of, what they call it, you do a poke to say, what does it really mean to you that we've had these increasing numbers the last few years? I think last year, we had 49,000 suicides in the U.S., and that's the highest number kind of ever recorded. And the third point is I also am very sensitive, like many of us are, to the fact that these numbers are tending to increase during the COVID pandemic. Thoughts about those considerations and what you think as a psychiatrist our audience should be mindful of and thoughtful about, because particularly we want to be more mindful of the risk we may have kind of going forward.
Well, the first comment I had is that earlier today I received notice of a program that is being held at Dartmouth College that is going to feature the current Surgeon General and 7 of his predecessors, including David Satcher. And the title of the program is The Future of Mental Health and Wellness. It's going to be held Thursday, September 28th. It's a free webinar. And in fact, the reason that this webinar is being pulled together, and Sanjay Gupta is going to be the moderator, is that they're supposed to be talking about the mental health crisis that is occurring in America right now. I think, as you're suggesting, Ron, that the numbers indicate that there is rising distress and stress, increasing level of psychiatric emergencies out there. And I think there's a number of factors that have contributed, and in particular in our community, whether we're talking about structural racism, which has in part, we felt the effects of climate change disproportionately, and the increasing stress that's induced by the disasters that are occurring around the country and around the world. We're dealing with the opioid crisis. We're dealing with the pandemic. There are a number of stresses that are leading to increasing distress in our population and increasing loss of hope and resilience to dealing with the stressful lives that we have encountered.
Yeah, by definition, I think the risks seem to be greater or worse in traditionally the underserved, you'll call it, communities. You describe, I think, very articulately the fact that they are complex in part because they're multiple and they're additive as compared to canceling one another out. We always hope that we're involved in activities and programs that modify or reduce that risk. Or Dr. Conco started earlier and spoke a bit about this. I mentioned barbershops. I know he's got a basketball program. I want to make sure I came back to you, Doctor, in case you didn't get a chance to fully describe what you think the future of that program looks like. And I'd love for you to give some numbers. How many young boys have you accessed, and how many, because I know some of the residents are involved in this with you. We're very proud of that program, I think, here at LSU, and I'd like to make sure you have a chance to kind of describe it in detail to our audience tonight.
Yes, for sure. It's called Health and Hoops with doctors, and this program was built specifically to empower resilience upon Black males, Black adolescent males in particular. And that program is informed by the Positive Youth Development Curriculum, which has a 6C approach. And that 6C approach are theorized to lead to pro-social development. And those 6 C's include character, competence, confidence, compassion, community. And what we do is each encounter, we meet once a week, roughly with nearly 20 to 30 young males per week at one of the local recreational centers here. And what we do is we engage, on each week, we engage any one of those 6 themes, and we use it as the theme of the day. And as we play basketball games, we score to the correct and complete spelling of that individual theme. And after the game, we engage the youth and discuss how those themes not only apply as an athlete, but how it's also applicable in real life in the social community. And the next week, when we meet again, we ask them, what did they learn and what did we speak about last week? And they're able to communicate what they've learned and how they have applied it over the past week in their community. And we apply this format using a strength-based intervention, the theme that I had spoke about previously, understanding that youth have innate capacities that may be underappreciated and not incorporated into common conventional educational curriculums. So therein lies a gap. And so we use basketball as a way to teach these young ones these positive skills that can help them in life. And it's just been great. We wear scrubs when we play basketball with them. So we also give them the opportunity to kind of have that "you see me" type of impact, kind of in the same way where you would have an athlete wear a jersey and will go to a school and the kids would see. And it's led by a group of residents, but in this fall semester, medical students have taken the lead. I was there yet on Tuesday, and it was great. And so, so this program aims to ultimately just improve various psychosocial outcomes for young teenage men as they enter into adulthood, with the hopes that they can reduce their risk for internalized and externalized violent activity.
Yeah, outstanding program, as mentioned earlier. I'd comment that at the National Medical Association meeting, which was here in New Orleans this summer in late July, there were discussions, I think, about this program and programs that are similar. I keep mentioning barbershops because so many of them revolve around a barbershop, kind of becomes symbolic of a site in particular communities where persons can go and share thoughts, ideas, maybe perhaps where they feel comfortable, and maybe perhaps where they actually feel safe. I myself personally spent a lot of time at a barbershop. At this age with less hair, I don't go to barbershops much, if you will. But in my community, growing up in Beaumont, Texas, 50 years ago or more, it was a normal activity to go and spend at least an hour, sometimes more, with my father in the barbershop on a Saturday. That was kind of what you did, and there was a lot of discussion, and theoretically a fair amount of problems were solved. But I love your point. You actually got to see individuals in different settings. There's probably a lot of role modeling that took place in those settings, and a lot of good that occurred, a lot of intellectual discussion. And I can certainly say, after all of the years of going multiple times, I never saw or appreciated any violence. Persons were able to describe and address issues, and at times discussions could become heated, but they could do so, I think, with the value of the spoken word rather than resorting to physicality. A learning experience that may not be as articulately described as what we do in medical school settings, but I think just as poignant and just as effective. Interested, Dr. Bryant, in your thoughts about that particular program or others along that line. These do seem to be some vectors that can be helpful in our community and can prevent, if you will, emergencies.
Agreed. And I guess I would like to also suggest some individual activities or resources out there that don't require the creation of a program, but can be helpful in individual sorts of emergencies. One of those things being having Narcan available, an opioid antagonist. Narcan is a medication that can be life-saving for someone who's had an opioid overdose. I would encourage brothers out there who may, if you have to take opioid for pain management, or you have a family member who has a problem with opioid dependence, asking your physician if you could have some Narcan available, so that just in case you come across an opioid overdose, that you can help save a life. Another resource that is out there that I think we talked about police involvement and how that can be deleterious to the health of someone who's having a psychiatric emergency, is that if you do call for police help in such a situation, that you demand that the officer that comes to the situation, that they have CIT training, or crisis intervention training. That's something that many police departments now have, and that it should be a requirement before they get involved with dealing with a psychiatric emergency. They learn in that training some of the aspects of what some of the signs of psychiatric disorder, how to handle, de-escalate situations. Police officers shouldn't be involved unless they have that sort of CIT training. Another resource that's particularly valuable in psychiatric emergencies is that there's a phone number now that one can call that is specifically suited for psychiatric emergencies, and that typically does not get the police involved. Rather than calling 911, call 988. That number is now a national number that's been created to try to help deflect psychiatric emergencies away from police involvement and more towards psychiatric treatment. And the final thing that I wanted to mention is that for all of us, I highly recommend that we spend some time regularly practicing some form of mindfulness to deal with the stresses out there, to help us to temper whatever past traumas that we may have to prevent our own psychiatric emergencies, whether that's through daily prayer, meditation, relaxation, deep breathing techniques. There are a plethora of mindfulness techniques that one can Google and see online some of the different methods. It's something that I practice here at the University of Miami with my trainees every day before starting rounds, to get us in the mindset to really practice good, compassionate care. And so I definitely recommend that we all spend some time doing that to help us better help one another.
Well, just simply excellent points, and I think I'll repeat them, I think, for our audience. And also, we have a follow-up audit, so to speak, but it's Narcan availability as an opioid antagonist for risk of opioid overdose, CIT training or crisis intervention training. Law enforcement will get called on emergencies to have this particular mental health type training, if you will, and hopefully be able to differentiate between mental health concerns and those that may not meet that criteria. I was in Texas early in my career, and we had constables who were law enforcement officers who had that type training, and they were to be the ones that would be called out rather than typical law enforcement who may not have the additional type of specialty training that you, I think, described. The 988 number, which we think that everyone in the country should be mindful of. Very often you don't have to call somebody to come with a gun, a policeman, to a city that doesn't require such, and then practicing a mindfulness. Very happy to hear you engage with that yourself with your residents. I mean, that's really putting your money where your mouth is and really treating, I think, our trainees in a way that helps them, I think, very much appreciate and understand what we encourage them to teach and educate, I think, others about and their own patients. Tremendous points, really, really tremendous points. Let me give Dr. Concord a chance to respond to that. And I want to make sure that I give Dr. Bryant these 3 questions that we had earlier. I want to make sure you have a chance to address them. But any follow-up, Dr. Concord, on Narcan availability, CIT training, the use of the 988 semi-emergent type call or urgent call it's called, and issues of practicing mindfulness that you might want to speak to.
Yes, for sure. The significance of Narcan cannot be understated whatsoever. I believe in New Orleans, they may have, I think, passed a law where it's now available over the counter. So please, understand that there's access to Narcan from your provider, potentially from your local retail stores. It's simply a lifesaver. Mindfulness, of course. I mean, we speak about trauma, but we all have our own degrees of personal trauma, and we all navigate it. So mindfulness is a great technique to help exercise the weaknesses and faults within ourselves to help our resilience day in and day out. And I agree with all the other points made. And also want to emphasize the importance of CPR training as well. That's also available from your local hospitals. You can potentially become informed of that.
Well, I ask each panelist today, and I thank you guys very, very much for what's been, I think, a wide-ranging and a very fruitful discussion. Generally at about 7 Central, 8 Eastern, we'll move to a few more directed questions before we begin to work toward closing out. And we'll close out here within the next half hour or less. Dr. Bryant sent 3, and I'll give you a chance, Dr. Bryant, to address them all in turn. I'll go and read each of them and give you a chance to kind of respond overall. I want you to talk about how you define or what constitutes a psychiatric emergency. Also, why do you think, in your experience, police are so often involved? And third, what's the role of trauma in both starting or precipitating or perpetuating psychiatric emergencies? So what constitutes a psych emergency? Why are police so often involved? And what's the role of trauma in perpetuating psych emergencies?
Well, I alluded to the psychiatric emergencies earlier this evening in terms of the three broad areas. Typically, it's a concern about danger to self, danger to others, or just not being able to care for oneself. The police are so often involved in these emergencies just because of the history of their role in our communities and the lack thereof of psychiatric or mental health resources. Before we learned so much about mental health and broke down some of the stereotypes about being, quote, crazy, unquote, the police were turned to try to deal with these situations inappropriately. But laws have been developed such that if someone has to be hospitalized against their will, oftentimes it's the police that are the ones to enforce their being brought to a treatment facility. And the last question regarding the role of trauma, again going towards some of the themes that Dr. Okunrako was stating with regards to his programs for resilience. It oftentimes begins in childhood, the traumas that lead to a recurring theme, re-traumatization, and psychiatric emergencies. It's been shown that adverse childhood experiences, witnessing trauma, being neglected, being abused, witnessing substance use in the family, that 4 or more of those types of experiences in childhood raises the stakes immensely. There's roughly 12 times the risk of trying to commit suicide, 22 times the risk of ending their lives in suicide as an adult if they've had these experiences as compared to children who have never had those sorts of adverse traumas. And so it's really important that we build support, care, resilience in our communities to protect our children and our adults so that they can live better and more fruitful lives.
Appreciate it. I think that those questions are very timely and important, I think, for all communities, and certainly I think our community particularly. I think that my experience, similar to yours, has been that the better families and neighborhoods and communities understand what may lead to such emergencies and the like, we may be able to engage in some protective behaviors that may modify the risk of self-harm and suicidal ideation, let alone action or activity. I'd also share that we're under a fair amount of pressure in our profession. In many professions, you don't want to lose a patient, but it happens in many settings. It's the nature of primary care and having a lot of patients with substantive organ failure, heart and lung and kidney. But for psychiatrists to lose somebody to suicide can be overwhelming to the psychiatrist as well and to the professional. So I think that here are doctors, whether psychiatry trained or ER, or as Dr. Okonkwo is, have that risk of seeing someone and feel like we actually didn't really do enough. So much as the resource issue that you described, I think very well tonight, comes into play, because I think that some of the responsibility on our shoulders grows when we can't manage these issues well. And it's hard to manage them well if the patient isn't able to receive some resource support and help and the like going forward. Dr. Okonkwo, I'd love to hear some thoughts that you may have as well. You've, I think, spoken well tonight about the environment, the community that I guess you work in. You mentioned it was an area in inner city New Orleans where social determinants of health can be a challenge. So also something as simple to many of us is writing a prescription and find out later the patient could never really get it filled can be a huge challenge for doctors trying to get patients to a level of satisfactory, let alone healthcare outcomes. Be interested in your thoughts along that regard as well.
Yes, so I believe from the ER perspective, there's a responsibility to triage trauma to triumph. And for me, what that means is also considering social work There's hospital violence intervention programs that actually navigate into the emergency department once they're actually activated into coming to assess a patient. There are some of these tertiary sources that can actually provide as a gap to help build the resilience to actually have compliance with medications and different forms of therapy that often are not necessarily facilitated by, that can be really used to actually increase that outcome of medication compliance. So triaging trauma to triumph, to me, is truly about that, and not just limiting or being limited from a clinical perspective in expecting, quote unquote, a patient who may be at risk to comply with a medication that they may not necessarily know why they should comply to.
All fair points. I think the discussion tonight has been, again, I mentioned timely earlier. I think really very salient. I hope our audience has kind of heard, I think, very key messages of resiliency was discussed earlier. Issues of heightened degrees of risk, why some communities, some individuals are at a great degree of risk. I did want to talk a little about sports tonight. Played a lot of sports my entire life. So I think that all of us are very mindful after watching that event with the football player in Buffalo last year. And then hearing that happens most commonly with younger persons, with children, very often in other sports, not even in football, it could be in soccer or American football. So the fact is, those are thoughts that I think we should all be mindful of and not be surprised by. Educating our community, we find to be one of the primary goals and effective vectors that we offer, I think, with this program. And I certainly want to thank both of you tremendously for your time and your energy, your effort, and your expertise. We often will end with giving you a minute or two to make kind of summary comments. In addition, we encourage, please don't be bashful. If you want to tell us where you work and your organizations that you're in, I'm going to go ahead and brag on Steve Bryant because he's the incoming president of our Black Scouts of America this November. Very happy for him, very proud of him, doing great work in that regard, as well as Dr. Okonkwo, who I think has the world ahead of him with the wonderful things that he's moving forward in ER medicine, but also what I consider a psychiatric piece, if you will. Why don't we start with you, Dr. Bryant, and give you your final comments.
So, speaking of the Black Psychiatrists of America, just to let the Brotherhood know that, of all the psychiatrists in America, only about 2% of those psychiatrists are Black. And the Black Psychiatrists of America, we're striving to make those numbers greater, to have a greater influence on the practice of psychiatry. Many of the problems that we've talked about this evening are in part due to the practices of psychiatry, majority psychiatry. And in fact, in 2021, the American Psychiatric Association, the majority group organization for psychiatrists, issued a statement apologizing for the racism that organization had fostered in the treatment of people of color. And we in the Black Psychiatrists of America, of which Ron is a prominent member of that organization, we're striving to have an impact, to change the effects of structural racism and how it's affecting our communities and hopefully having better outcomes in the future. I'm glad to be able to share some of my thoughts with you all and look forward to continuing discussion and engagement with all of the Brotherhood regarding how we can improve the mental health of Black America.
Well said. Very much appreciated. Dr. Okonkwo?
Yes. So resilience was one of the themes of the night, and I would like to implore where resilience can be found. And from all intents and purposes, data has suggested that resilience is found in identity. So I would advocate all to truly re-engage oneself with one's identity. Now, racial socialization does not allow African Americans to truly appreciate their identity. So I would truly advocate for ethnic studies, for utilizing various ethnic resources to engage that part of oneself that is resilient, that has in fact demonstrated capacities which were demonstrated prior to the transatlantic slave process. So I'm thankful to have this opportunity, and thank you, Dr. Bailey, and thank you, Dr. Bryant, as well.
As well, you guys were just absolutely excellent tonight. We'll end with my closing comments. Thank the entire Brotherhood for supporting this project. We've been doing this for 2 years now, every Thursday night from 6 Central until about 7:30 Central with a healthcare topic. Often mental health or psychiatry occurs once a month on the third Thursday. And I'm remarkably appreciative of my two good friends, brothers Bryant and Okonkwo, for participating tonight. We end by thanking our General President, Brother Dr. Willis Lonzer, for having the idea to conceptualize this issue. Many are aware that we now are an organization with two kind of healthcare initiatives. We have a typical health and wellness committee, which does what most organizations have, health committee, and they do a very good job. I think they actually are outward facing for what we're doing in the community and what we want others to know we're involved in. But now we have an inward facing entity, that's the so-called Surgeon General Initiative. And the goal is to be for brothers and by brothers and about brothers, to particularly focus on the health and well-being of African-American men, specifically African-American alpha men. I end by also thanking Brother Dr. Jeff Sterling, our Surgeon General, for really working to pull this together. It takes a lot of work and effort, along with, I think, our IT support. I want to thank all of them as well. This has gone extremely well, I think, over the last 2 years. We hope to kind of continue it. I thank the audience for your participation tonight. I really appreciate all of your effort, everything you could do to help improve the quality of healthcare lives, I think, of our members and our community are worthwhile. Thank you guys very, very much, and have a good evening.